we can begin. Welcome, everyone. My name is Halima Siddiqui, and I'm the project coordinator at Health Nexus. Health Nexus oversees several provincial initiatives related to FASD. The FASD provincial website, where you can find recent and up-to-date information about what's happening, learn more about resources and tools, and find out services available in your local community. We also allocate subsidies every year to 40+ support groups for individuals with FASD and their families. And we designed an online training for service providers from various sectors, including healthcare and nursing, education, mental health and addictions, justice and corrections, and community and social work. I'd also like to begin today's presentation with a land acknowledgement. We would like to begin by acknowledging the Indigenous people of all the lands that we are on today. While we meet today on a virtual platform, let's take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous people and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. Now I'd like to introduce you all to our speaker today, Dr. Katy Flannigan. She's a psychologist and researcher whose work is focused on the clinical implications of neurodevelopmental diversity. She has a special interest in FASD and factors that influence day-to-day functioning, well-being, and outcomes for individuals and their families. Catherine has been involved in the FASD field since 2006 as both a researcher and service provider with children, adults, and families affected by the disability.
Okay, so thank you so much, Halima, for introducing me and for inviting me to speak today. I'm really excited to present on some of the research that we did in the last couple of years. I was telling Halima earlier that we haven't actually presented this research yet, so it's cool to be able to share some of what we did and our findings with everybody here. So thank you so much for joining and for having me. So, Halima did a land acknowledgement already, but I also would like to take a minute to do my own. I'm currently joining our meeting today from Treaty 6 territory, which is a traditional gathering place for many First Nations, Métis, and Inuit peoples, including the Cree, Nakota Sioux, Blackfoot, Dene, Saulteaux, who have gathered on and cared for these lands for generations. And whenever I give a land acknowledgement, I also like to take a minute to reflect on my relationship with the land and the history of the land and the people who were here before me. So I think about the Indigenous people who I'm grateful to work with and learn from. Excuse me. I'm continually striving in my work and in my personal and home life to take concrete and tangible actions towards reconciliation through community engagement, and especially at home with my family and my kids to learn and understand more about our history and the gifts that come from these connections with the land and Indigenous peoples and all these relationships. And so lately, what this has looked like is that my kids and I are learning some Cree words, and they have come home from school with a new vocabulary that they're sharing with me. And this photo here that I wanted to share, I took this when we were driving from home in Edmonton to northern British Columbia over the Christmas holidays. My husband's family lives out there, and as we were driving, the trees were coated in this beautiful snow, and we were driving through the mountains, and it just was a moment that I felt very grateful for to call these lands my home. So I wanted to share that photo. A little bit about me. Thank you, Halima. You gave my bio. I wanted to give a little bit of a personal introduction as well. So, as you said, my name is Katy Flannigan. I'm from Treaty 6 or Edmonton. I was born and raised here in Edmonton, except for a couple of years when I was going to school out west on the west coast. My father is an immigrant from Scotland, and my mom was born here from a couple hours north of Edmonton. So I grew up with my brother. My brother and my husband's family currently live in BC, so we do spend a lot of time visiting there. The photo on the right is me and my two little guys, Sam and Jacob, and my husband, Ryan, who's a teacher. This is a photo of us taken last summer when we were visiting my brother in the lower mainland. So we do get to spend a lot of time between here and there in the mountains and enjoying the ocean. So, as Halima mentioned, I'm a psychologist as well and a researcher with the Canada FASD Research Network. So, this is my work family. A photo on the left is the CanFASD staff taken at our conference last fall. Yeah, just over a year and a half ago when we were in Saskatchewan for our national conference. And then the photo on the right is from actually the first event that I ever attended as staff of CanFASD. We hosted an event or a workshop in Regina where folks with living experience and service providers and policy folks and researchers all gathered together to set research priorities for FASD research moving forward. So this was nearly 10 years ago, and it was my first event as a CanFASD staff, and I've stuck around ever since then because it's such a special place to work. And one of my favorite parts of working for the network is having the connections and the relationships with so many different people from different backgrounds, and it gives us a beautiful chance to really work collaboratively and learn from one another about what kinds of work and what kinds of research we can do to advance the field for people who are actually impacted by the research that we're doing. So I was invited today to speak about sex-based differences among people with prenatal alcohol exposure and FASD. So I do really like to talk, especially about FASD, so I'm going to try and keep myself contained. I'm going to start off with a little overview or a snapshot of the literature on sex-based differences in people with disabilities generally, and then more specific to FASD. And then I'll spend the bulk of my time sharing findings that we reported in a recent study, a CanFASD study. And then finally, I'll wrap up if I have time. I might have to speed through with some emerging research and ideas for next steps that we can take to continue moving this field forward. So to start off, kind of contextualizing our study, what does the research on sex and gender and health research tell us about folks with disabilities? So I want to preface this by saying that I am not an expert in sex and gender research or health research for that matter. I do all of my work in FASD, and I have learned a great deal through working on this project about sex and gender, but they are such complex concepts and nuanced with dynamic factors and subtleties that I won't be able to do justice in this short presentation. So just to preface it by that, there are people in CanFASD who know much more about sex and gender than I do, but this is just sharing what I have learned and what we have learned through the research that we did together. So, what is meant by sex, gender, and their interactions, I've learned is not well understood or very often described particularly well in health research. So, for the purpose of today, the way that we're conceptualizing sex is referring to the biologically based factors, characteristics, and processes um, that are the contrasting aspects of male and female bodies that impact health and response to intervention. So, these are factors like anatomy, physiology, genetics, metabolism, etc. Whereas gender is an overlapping but distinct term used to refer to social and cultural factors and processes. For example, gendered roles, relations, identities, and systemic and institutional practices. So both of these terms impact health, well-being, and experiences. And both in health research are often used interchangeably or overlooked entirely in health research. This is a problem because the dichotomous distinction between male and female bodies really oversimplifies the complex and the nuanced and dynamic interactions between sex and gender and the related life experiences that come along with sex and gender. And it negates the oversimplification, negates the broader social cultural factors like geography, education, socioeconomic status, religion, that intersect with sex and gender factors. So that is all to say that this is a highly complex and nuanced topic in which I'm not an expert, but I want to acknowledge that this is very complex. And although we did use the dichotomy, male female dichotomy in our study, I want to acknowledge that it is much more complex and nuanced than that. So, in terms of the literature on sex and gender and the factors that relate to disability, there's not been a lot conducted specifically with FASD, but there has been a bit conducted with folks with other neurodevelopmental disabilities, particularly autism, ADHD, learning disorders, intellectual disabilities, and communication disorders. So, what the researchers in these areas have reported is that the prevalence, onset experiences, clinical presentations, and the co-occurring needs that happen for folks with disabilities have important sex-based differences. So, for example, in terms of prevalence, most neurodevelopmental disabilities are more common in males than females. In terms of clinical presentation, for example, and I say this in a general sense, not that every person will fall under this description, but some research has shown that among folks with autism, for example, females tend to have better social communication, whereas males engage in less self-injury behaviors. Or folks with ADHD, females tend to have more internalizing symptoms, whereas males tend to have more externalizing symptoms, etc. So there are important sex-based differences that have been found in the broader neurodevelopmental disability literature. Now, with respect to FASD, there has not been a great deal of research looking at sex and gender-based differences. Most of the studies that exist to date have been conducted with animals. And so what we've learned from the animal research is that in general, male bodies tend to be more susceptible to the impacts of prenatal alcohol exposure than female bodies. So some of the studies that researchers have conducted, they have looked at the differential impacts of sex on metabolism, fetal growth, brain volume, some cognitive functions, behavioral functions, and social interactions. And in general, males tend to be more susceptible than females. There is a smaller number of studies that have involved human participants. And in this researchers have shown sex-based differences in patterns of diagnosis. So in large clinical studies, it tends to be that clients who attend clinic are more often male than female. So there's an overrepresentation of male participants in these studies, although this research is mixed depending on the setting. There have been other human studies to look at brain function and clinical characteristics of people with prenatal alcohol exposure and FASD. So, for example, brain volume has been looked at, where there's different patterns of reduction in brain volume for girls and boys. There's been research on auditory processing and the patterns of brain activity that underlie this processing. Eye movement has been examined in terms of sex based differences. Stress response, so the brain pathways that underlie sensitivity to stress and regulation and cortisol reactivity. So there's all these very focused topical studies related to male and female differences among people who have prenatal alcohol exposure. One interesting finding from some of these studies is that there are age-related differences. So there was one study where the researchers looked at children and found that in young boys with prenatal alcohol exposure, the boys were more susceptible to the impacts of prenatal alcohol exposure. But then once several years had passed and after age 7, girls tended to be more vulnerable to certain impacts of PAE. So we really don't know a lot about what this could look like across the lifespan. And although these studies are important stepping stones to help us understand what these sex-based differences may be, they're all quite small and targeted. So we also acknowledge within this study and this work more broadly that sex and gender interact with each other as concepts, and they also interact with other intersectional characteristics to shape many things that a person would experience and many things that a person or many needs that a person might have. So for example, there are intersecting impacts of sex and gender on alcohol use, where males and females engage in different patterns of alcohol use. There are also sex and gender based impacts on the expectations that we hold for people who use alcohol. So women are held to different expectations than men. There are also sex and gender based factors that impact stigma and the experiences and expectations that we place on people with FASD. And then finally, treatment options can be vastly different depending on sex and gender based factors as well, where there are certain barriers for some genders and less barriers for other genders. So, with all that said, there are a number of gaps in our understanding of sex and gender based differences in FASD. Although, despite the important first steps that I described a couple of slides ago, we still have certain questions that we don't have the answers to. As I said, most of the studies conducted to date with people with FASD have been really targeted in terms of what their area of focus was. The age groups tend to be quite narrow in that most of the research that I mentioned earlier has been focused on young children. They're small sample sizes, and often they're clinically referred samples, which means that they're kiddos or young people who have access to clinical diagnostic center, whereas that's not necessarily generalizable to the general population of people with FASD. And very few of these studies have looked at how sex based or gender based differences might manifest in daily life or change across the lifespan for people with FASD. So these nuances and how what meaning these differences have has not been very well explored. So in order to fill some of these gaps, here is a study that we conducted a couple of years ago. Um, it's important that I point out that we did look at sex-based differences, not gender-based differences. And in order to address some of the limitations of focusing solely on sex-based differences, we really tried hard to interpret our findings and conceptualize our research with consideration of the ways in which gender influences interact with sex-based differences that we identified in order to impact the diagnosis of FASD and the expression or presentation of people with FASD. So these were my co-researchers. Dr. Nancy Poole is the expert on sex and gender in FASD. She's based out of Victoria, and she works with the Women's Centre of Excellence in BC, and she is our research lead in FASD prevention. So she really led a lot of the conceptual pieces in terms of how we really make sense of the findings that we're reporting in this study. Dr. Jocelyn Cook, she works for the Society of Obstetricians and Gynecologists of Canada in Ontario, and she's a real hard scientist. She does a lot of big data, and she was another of the co-authors. And then Kathy Unsworth is our managing director at CanFASD, and she's an expert in public health. And so all of our perspectives were brought together to interpret these findings that I'm going to be sharing with you shortly. Our overall research question, although we did a lot of things, which you'll hear about in a moment, our research question was, we wanted to know what differences exist in clinical presentation and experiences of environmental adversity for males and females with prenatal alcohol exposure assessed for FASD across the lifespan. And that is a mouthful, so I will break down exactly what we did in a moment. In order to answer this question, we analyzed data from the National FASD database. This is a pan-Canadian data set based on clinical information collected across the country. It's an online bilingual platform that 29 diagnostic clinics from across the country contribute to. And so there are 8 provinces and territories reflected in the database, and clients reflected in the database are across the lifespan from infancy to older adulthood. As far as I know, this is the only national FASD database that exists in the world, and so we're very lucky to have it in Canada. Essentially what happens is when folks come for an FASD assessment and diagnosis at participating clinics, all of the clinical information that is collected at clinics is entered into the database, and then it's anonymized so that we at CanFASD and other research institutions can look at trends and patterns across the country for folks with prenatal alcohol exposure who are assessed for FASD. As of last year, we've had nearly 5,000 records entered into the database, which is a quite huge and impressive data set for, especially for FASD research, where participant samples tend to be quite small typically. In terms of the clinical process that's followed for the database, all clinics who enter, all the 28 clinics who contribute to the database, follow the 2016 Canadian guidelines for FASD diagnosis, which includes multidisciplinary assessment, most often involving a physician, a psychologist, speech language pathologist, and then other professionals and service providers, depending on the clinic and the client. But all clinics, regardless of location, follow the diagnostic guidelines. Assessment happens at the clinics where the diagnostic team does a comprehensive neurodevelopmental evaluation as well as a medical and social history and confirmation and documentation of prenatal alcohol exposure. So all clinics, regardless of where they are, follow the same process. We extracted data for this study in December of 2021, and we excluded any data that had been collected before 2016 so that we had consistency in the ways that the data was collected. So all the data that we examined was collected between 2016 and 2021. We looked at a whole bunch of things. These are the broad categories of factors we looked at to see whether we could identify sex-based differences for folks who are represented in the database. Reasons for referral was one area that we collected, and these include just the reasons why somebody is referred for an FASD assessment, and that could include difficulties with school or behavioral issues, learning difficulties, adaptive difficulties, confirmation of prenatal alcohol exposure. There's many different reasons for referral. So we did want to see whether there were sex-based trends in that area. We also looked at demographics. So we looked at sex, not gender, but we looked at sex, age, region where the individual is in Canada, and placement type. So we record whether an individual was living with their birth family or foster family, adoptive family, or group setting or institutional or psychiatric hospital, etc. So those are the demographic variables that we collected. We also looked at the physical indicators of prenatal alcohol exposure, which are things like delayed growth, microcephaly or small head, and the sentinel facial features associated with FASD. We looked at brain function. So again, this is the areas of neurodevelopmental evaluation that's conducted at clinic. So that's 10 different areas of brain functioning, including adaptive function, executive function, affect regulation, attention, cognition, language, memory, motor skills, and neuroanatomy. And I will not be asking you to repeat those later, so don't you worry. FASD diagnostic outcomes was another area that we looked at. So this is just the diagnostic outcome. So whether somebody was or was not diagnosed with FASD. And here we were looking to see specifically whether there was a difference between males and females in terms of the diagnostic outcome. The co-occurring health needs that we examined included physical health needs, mental health needs, and neurodevelopmental diagnoses or needs. And environmental adversity was our final category that we looked at for data, and that included early life adversity and trauma, as well as difficulties in daily living, including things like trouble with school or trouble with employment, trouble with the law, unstable housing, things like that. So we looked at a lot of data. In order to be included in the study, records had to have confirmation of prenatal alcohol exposure. So sometimes when folks come to FASD diagnostic clinics, prenatal alcohol exposure is unknown or unconfirmed. And so we wanted to ensure that all participants in the study had confirmed exposure to alcohol prenatally. We also needed to make sure that there was data on sex, and we excluded cases where a person's assigned sex at birth did not match their gender identity recorded in the database, because we wanted to keep the focus on sex, because we were not equipped to analyze gender-based differences. We didn't have enough data to look at gender-based differences and the nuanced factors that go along with that. So if there was no information on sex, or if sex did not match the gender identity specified, then they were excluded from this study. With those exclusion criteria, we ended up with a total of 2,574 people, which is a nice, huge data set. The mean age of participants in our study was 15, but individuals ranged from 1 year old to 61 years old. Females were slightly older than males, so they were on average 16.1 years, and males were 14.6 years. And I mention that because in the analyses for the researchers in the group, or the data nerds like myself, we controlled for age in our analyses to ensure that age wasn't impacting things. 58.3% of participants were assigned male at birth. 67.5% were from the prairie region, so that includes Alberta, Saskatchewan, and Manitoba. Most people in the study were living with their biological families or foster families. There was also a significant difference, a sex-based difference in terms of living situations. So where males were more likely to be living independently, or in a supported kind of independent housing situation, whereas males were more likely to be living with biological parents or in inpatient or custody settings. So again, we controlled for living situation in all of our analyses to make sure that living situation wasn't accounting for the findings. Reasons for referral: most participants were referred because they had prenatal alcohol exposure and because they had behavioral difficulties or learning difficulties. Again, males were more likely than females to be referred for a FASD assessment due to behavioral issues or difficulty with the law. So that was another interesting demographic difference that we found, which I will discuss more in a little bit. So the first aspect we wanted to identify whether there were any sex-based differences was diagnostic outcome, as I mentioned. We found no difference in diagnostic outcome or physical indicators of prenatal alcohol exposure. So there are no differences in the total number of sentinel facial features, presence of growth restriction, or microcephaly. Across both male and female participants, most were diagnosed with FASD without sentinel facial features. And that was the same for both male and female participants. Where we did find sex-based differences was around brain function. So across areas of brain function, we found greater impairment in participants assigned male at birth. Both the total number of brain domains that were identified as significantly impaired was higher in male participants. And in particular, males had higher rates of impairments in motor skills, memory, attention, executive functioning, and adaptive functioning. So this is consistent with past research that examines the brain-based impacts of prenatal alcohol exposure and the elevated vulnerability of males compared to females. Next, we looked at the co-occurring health needs, and as a reminder, this was physical health, mental health, and neurodevelopmental diagnoses and other conditions. We found, again, sex-based differences in these areas where female participants had higher rates of endocrine problems. So these were diabetes and thyroid diseases were more common among female participants than male participants. And mental health wise, female participants were more likely to have anxiety diagnoses and depressive and mood disorder diagnoses. On the other hand, male participants were more likely to be diagnosed with ADHD, conduct disorder, and oppositional defiant disorder. Next, we looked at environmental adversity. And again, this was early life trauma, early life adversity, and difficulties in daily living. Among female participants, we did find higher rates of trauma, although we found high rates of trauma across the whole sample, participant sample, the rates of trauma were higher among female participants. And there were interesting differences in the types of trauma experienced by males and females as well, which I'll mention a little bit later on. Similarly, female participants had higher rates of problems with victimization and custody issues, whereas male participants had higher rates of problems with school, and this is defined as school expulsions, suspensions, and needing the assistance of an educational assistant. And male participants also had higher rates of problems with offending and incarceration. Finally, we were interested to see what differences occurred across age groups. So we broke the sample down into preschoolers aged 0 to 5, school-age children 6 to 12, adolescents 13 to 17, transition-aged youth 18 to 24, and adults 25 plus. So what we found across these age groups was that there were no sex-based differences in preschoolers in any of the variables that we looked at. They were males and females had the same clinical presentation and experiences of adversity. There were a few emerging differences in school-age children. So among males and little boys who are school age, they had higher rates of ADHD and school problems than little girls. The most differences that we identified were actually in adolescence. So males and across the board, males had higher difficulties in attention, conduct disorder, school problems, and problems with offending and incarceration, similar to what I mentioned on the previous slide. In adulthood, the experiences diverged more by sex and gender. So this is where female participants were reported to have higher rates of trauma and victimization, whereas male participants were reported to have higher rates of offending and incarceration and attention problems. So this is where things really started to diverge based on sex. So I have a couple of takeaways to summarize and sort of contextualize in the literature to date and kind of give a sense of what we're thinking of around interpretations and what this means for folks with FASD and those who support them. The first takeaway is that male participants had more pronounced brain impacts. And as I mentioned earlier, this is consistent with previous research, both with animal studies and human studies. It's consistent with the early impacts of prenatal alcohol exposure being more harmful, or little boy brains being more susceptible to damage from prenatal alcohol exposure than female brains. An important step forward from our study is that these findings extend these results beyond childhood, where almost all of the studies conducted to date have been conducted with children, whereas our study shows that these challenges that are higher in males exist across the lifespan. Another takeaway is the sex-based differences in mental health and neurodevelopmental disorders, co-occurring neurodevelopmental diagnoses. So again, up until now, all we've really known about mental health profile and neurodevelopmental needs among people with prenatal alcohol exposure in terms of sex-based differences was from childhood. So now again, we extend those findings into adolescence and adulthood, again, where we showed, similar to the general population, that male participants tended to show more externalizing problems like ADHD, conduct disorder, and oppositional behavior, whereas females tended to experience more internalizing problems like anxiety and depression. So again, these findings align with the non-FASD literature, so it wasn't a surprise to see that these sex-based differences, where males are more often diagnosed with externalizing disorders and females are more commonly diagnosed with internalizing disorders. one of the ideas that we had for potentially why these sex-based differences exist for folks with PAE is the impacts that prenatal alcohol exposure has on the stress response system. So as I mentioned in, excuse me, in the overview of the literature earlier, prenatal alcohol exposure impacts the stress response and the underlying reactivity of the brain to stress. And we also know that stress response and reactivity can impact mental health trajectories. So it could be this biologically based or this sex-based biological factor of the impacts of PAE on brain development in utero can set up a trajectory for different mental health experiences across the lifespan. But it goes beyond that, I believe, and I think that it's not only the sex-based factors that would be at play, because we also have in our society gendered conceptions of mental health for all people, not just those with FASD, and not and these factors are at play both in terms of identifying and diagnosing people with disabilities or people with mental health concerns. We have these gendered conceptualizations of what mental health looks like for men and women, with or without FASD. And also sex and gender both impact who might receive a specific diagnosis, what diagnosis is made, and what treatment options are offered to folks who have mental health diagnoses. So both here, our suggestion is that both sex and gender are at play. Another takeaway is the male overrepresentation in our participant sample. So like previous studies, there were more males than females in our sample. And this is, like I say, common across different studies of clinically referred people, which means that people refer to FASD clinics, whether that's children or adult clinics, there tend to be more males who are referred. But interestingly, in our sample, when we looked at age group trends, in adults, there were actually more females than males. So the overrepresentation of male participants in the younger years may reflect that more obvious or readily apparent difficulties, like disruptive behaviors or externalizing behaviors that are present or seen in boys, lead to triggering a clinical referral, whereas if a girl is experiencing more internalizing symptoms, then it would not be as readily apparent, and clinical referral might not be as accessible for a young girl. This also could suggest that FASD is under-recognized in girls in the early years because of these differences in presentation, which could relate to barriers to services that uniquely impact young girls and women, and render girls and women less likely to be able to access clinical services until later in life, which points to a need for more awareness around the potential under-referral and subtler presentation for girls and women with FASD, so that we can support early identification and intervention. We also found important gendered experiences of adversity. So again, this could be an example of how sex differences may interact with gender roles, expectations, and how these responses differentially impact males and females. So as I mentioned a couple of times, this internalizing versus externalizing behaviors can have different impacts for boys and girls. So, for example, in young boys, we noted that there are higher rates of adaptive functioning difficulties and executive functioning difficulties. And it could be that these challenges or behaviors relate to problems in school. And then these problems with school lead to contact with the legal system, as we know that problems in school do relate to legal involvement. So this is just a possible idea of how these factors are at play and interact to impact boys and girls differently. Males and females also may respond differently to stress and trauma. Again, girls might tend to respond in an internalized way, whereas boys might tend in a more externalized way. And I also want to say that I'm referring to these using quite broad generalizations. And I want to again repeat that I don't mean that this applies to every single person, but these are the generalizations that we're noticing. So these differing responses from young boys and young girls that that occur in response to trauma and adversity result in different social responses and social consequences. So, what a behavior in a young girl might have a different social consequence than a behavior in a young boy. And finally, we had some important findings related to trends across the lifespan. And this, I think, is a testament to the gender influences interacting with sex based factors. So, we did notice that in early childhood, there were no sex based differences, but by adolescence and adulthood, there were a high number of sex based differences. And so, our thought or hypothesis or idea around how to explain this is that once individuals with FASD begin interacting and encountering social systems like the healthcare system and education and legal system, it's possible that the underlying neurodevelopmental needs and the mental health and behavioral needs conflict with the expectations, institutional expectations and systematic expectations, as well as responses that are provided when this happens. My hope is that this research can have a lot of helpful impacts. First, I think that our increased understanding of sex-based differences in folks with prenatal alcohol exposure give us better insight into the underlying um, the underpinning etiological, so the reasons why some of these differences in presentation might be occurring, and differences in terms of needs. So we can describe some of the ways that males and females experience FASD differently. And this hopefully, by better understanding these needs, can lead to more evidence informed assessment and treatment, as well as advocacy and policy decision making. So, another hopeful, important impact that this research may have is to identify treatment barriers that may be uniquely impacting males and females. We do know in the general population and other literature that gender stereotypes and inequality have profound impacts on treatment and outcomes. And so, this highlights the importance of gender sensitive healthcare and public policy. Whereas gender responsive healthcare and policy can reduce barriers and increase engagement and improved outcomes for all people of all genders, including those with FASD. Also, knowing the ways in which FASD presents differently in male and female individuals can help us to tailor responses more uniquely and inform the ways in which males and females might respond differently to different types of interventions or responses. Knowing more a little bit about the lifespan trajectories that may differ for males and females with prenatal alcohol exposure allows us to deliver more timely interventions that are more appropriate and hopefully can prevent some of the trajectories that the more the trajectories like such as school problems and involvement with the legal system and victimization, et cetera. And ultimately, together, the hope is that these findings and this better understanding of sex-based differences would lead to greater health equity for all people of all sexes and genders with FASD. In terms of policy practice implications, I was happy to see that there were some policy folks in the audience. So I'd be curious to hear about what you think, as well as the service providers and those with lived experience. I am looking forward to hearing your thoughts. Um, it's just nice to be able to translate this to another level beyond my little desk, my little research desk. So it's nice to think about the implications of this work. So the idea or the hope is that this research will lead to increased awareness among practitioners and policy makers to provide more tailored responses and services and allocate funding and resources to support FASD informed programs that are meaningful and relevant for both males and females and all genders of those with FASD. I'm hoping too that it will result in more gender sensitive healthcare and public policy. I mentioned earlier that there is a different pattern of trauma experiences for boys and girls, sex-based differences in their experiences of adversity and trauma. And while that is true, there were high rates of trauma across the entire sample. So I think that it is important to acknowledge the need for trauma-informed care for folks of all genders with FASD. And then this also calls for gender responsive practice and policy related to not only diagnosis and intervention, but also prevention. So FASD prevention, when the needs, the biological, psychological, and social and cultural needs of women and girls are met effectively and comprehensively, the likelihood of alcohol use and subsequent alcohol exposed births is reduced. So to summarize all of these findings and this data into one sound bite, although the complex constellation of clinical factors and life experiences of individuals with prenatal alcohol exposure and FASD may differ by sex and change over the lifespan, the cumulative impacts of these factors will require comprehensive, ecologically meaningful, strengths-based, gender-informed, and trauma-sensitive practice and policy, regardless of age or sex, for all people with PAE and FASD. So with that, I'm going to ask Halim. I don't know when I'm supposed to stop talking. I can share a couple more slides about emerging work, a couple of emerging studies and resources that have been developed since we published our study. And I'm not seeing or hearing her, so I'm just going to keep talking until she cuts me off. Um, a couple of studies since we published our study last year. There have been a couple of interesting papers published, and I won't go into great detail. I just wanted to share the titles with you in case you're interested in doing more reading and watching how the advancement in this area. So one of these studies, the one on the left, is a cool study about gray matter volume, and they look at around the interpretation of neuroplasticity. So that was a really cool study conducted by folks, I think that they're from the University of Calgary. Hi, Halima. Can I keep going or do we have to stop for questions?
We could go on for 5 more minutes, and then we can start questions.
Okay, then I can do 5 minutes. Thank you.
Yeah.
The paper on the right is a really interesting literature review. So it's not presenting new data, but it is a literature review on the interaction of sex and PAE across the lifespan. So they go over all of the research, both animal and human. And then the cool thing about this paper too is that they point out areas for future research. So particularly they ask questions around so like hormonal impacts on cognition, the impacts of prenatal alcohol exposure on later alcohol use among males and females, differences in immune function. So all sorts of these specific areas that there's really preliminary emerging evidence, and they're calling for more comprehensive studies in these areas. This is an issue paper that some colleagues of mine released last summer. It's a gap analysis related to sexual orientation and gender identity and expression among people with FASD. So these are the experts on sex and gender. I am not the expert on sex and gender. This is an excellent paper summarizing gender identity and expression for folks with neurodiversity, and it includes recommendations for practice and policy to better understand and support gender identity and gender expression in all neurodiverse populations, but specific to FASD. We're also doing our own research at CanFASD. These studies are currently underway. Neither of them are specifically targeting sex or gender-based differences, but both, because of what we learned in our database study, both include questions related to gender identity, how sex and gender are conceptualized in the identity of adults with FASD, and how that impacts well-being. And in our study of caregiver experiences and perspectives, we also ask about caregiver gender identity and their perspectives related to sexual development and gender identity among the individuals with FASD that they're providing care for. So our hope is that with this more intentional and specific, these specific questions, we'll be able to learn more about those more nuanced and dynamic factors that influence sex and gender-based differences. So our next steps, these are some ideas of ours that we think would be pretty cool to do more studies in. We're not doing them yet, so if anybody has ideas or wants to do them or has the motivation to work with us, please let me know. We think it's important to explore other relevant experiences that are relevant to sex and gender. So for example, how do caregiving experiences differ by gender, or caregiver responsibilities differ by gender? How do employment experiences differ by sex and gender? How do cultural identity and practices or how are they impacted by sex and gender? So there are other relevant life experiences that we did not cover or we were not able to report on in our database study, but that are important to continue thinking about. Longitudinal research is really needed. Our study was not, although we were able to look at trends across age groups, this was not a longitudinal study. So studies that look at the same individual over a long period of time would be really helpful to inform how sex and gender influence trajectories over the lifespan. Research on gender identity and diversity are also really important because, again, our study was focused specifically on sex-based differences, but this does not account, again, for the complexity and the nuanced influence of gender identity and gender diversity. Also, the other intersecting factors and characteristics that relate to sex and that relate to sex and gender are also important to consider in this research. And finally, under all of these next steps and under all of this research and these initiatives, I encourage and emphasize the importance of including and prioritizing the voices of folks with living experience. So as I mentioned, CanFASD is so lucky to have committees of folks with living experience who consult on research and we collaborate with on a regular basis to really understand what research would be meaningful and impactful for the lives of people who are impacted by FASD. With that, thank you so much for your attention, and I'm looking forward to questions. I'll leave my email on the last slide in case anybody wants to reach out about this study or anything else related to FASD. Thank you very much.
Thank you so much. It's been a wonderful presentation. We already have questions flowing in the Q&A, so I'll just start reading a couple out and then you can answer them. So the first question, someone has asked here, I wonder what implications might be added to the FASD experience if we consider that gender cannot be analyzed without considering culture. Would the results of the mentioned studies change if cultural factors for gender norms were added as variables?
Absolutely. I think that they would, and I don't know how they would because this is not my area of expertise and because it's such a complex area, and which is why part of the consideration around next steps is to look at these broader social, cultural, and temporal geographic factors, in particular cultural identity and variables that would influence sex and gender, because of course there are different conceptualizations of sex and gender across cultures, and it would be really, I think that it would be very important to look at that, and there probably would be differences. We don't collect cultural practices or cultural identity in the database, so we couldn't look at that, and we weren't equipped to look at those broader factors, but I think that that would be a very important and meaningful area for more research.
Thank you. The next question is, someone asked about, you mentioned all in study were either in a biofamily or in foster care, where none of them adopted. I have not heard that mentioned during the presentation. Also, have not heard anything about race.
Okay, so yeah, we didn't report on race. We didn't collect information on race in this study because again, we are not equipped to answer those questions around how that would impact sex and gender. But in terms of living situation, not all of the individuals in the study were in biological families or foster care. About 75% were. So about half of people were living in with either birth parents or family members. A quarter-ish were living with foster families, and the remaining 25 were in different types of living situations like adoptive or kinship or correctional service, correctional setting or things like that. So yeah, I just didn't report the full breakdown, just that most of the participants were living with their biological families or foster families.
Thank you. The next question is, does the database gather information about family history? Can we distinguish what is due to PAE and what is genetic? Example, higher susceptibility to some mental health.
Yeah, we do. The database does collect some very, very brief information about family history. For example, if mom and dad have, or mom and or dad have fetal alcohol spectrum disorder themselves or if their siblings do. Um, Not so much genetics. We do ask about genetic conditions that might exist for the individuals who are in the database, but that level of investigation isn't possible with the data that we have. Um, One really interesting study that we're working on right now, and we're almost finished writing up, is the impacts of other exposures in utero. So we collect information on different substance, like polysubstance exposure. So other, whether an individual has been exposed to cannabis, cocaine, other drugs, other substances, and so we're hoping to tease that apart a little bit more closely. But in terms of family history, it's we don't have a lot of data on that.
Someone commented, so how you're brought up affects this also.
I would think so. Yeah, I would definitely think so. And I think that all of our families have different conceptions of gender and sex, and within the little microcosm of our family, and then within the more broad system of our community and our society, I think all of that would impact. It's really impossible to narrow and isolate the impacts only on sex-based differences. So that, and I hope that I got that across, that it's oversimplified. The way that it's represented is oversimplified because that's what our data allowed us to do in the most clean way. But it's impossible to interpret any of these findings without considering how you're brought up and how where you live, what culture you're part of, how all of those would impact these differences and these experiences.
I think this one's a follow-up to your previous answer, but what about transgenerational trauma or family trauma history?
We do collect a little bit of data about trauma. Certainly, we do collect data about trauma within the individual who's being assessed, and sometimes clinics will add a little more open-ended data about what that might look like. So, say if during pregnancy mom was experiencing trauma, sometimes that will be noted, but it's not systematically collected. So the only thing that we systematically collect is whether the individual being assessed for FASD has experienced trauma, and then what type of trauma that might be. These
Okay,
are really good questions because we're constantly thinking about how to evolve the data set, because it's been, it's constantly evolving, and we've been collecting data for years and years. So it's good to have these questions and conversations to think about what we might be missing and how we can improve and evolve the data set.
next question is, diagnostic clinics provide you with data. Are they interested in learning from your research analysis of this data to improve their post-diagnostic support for people with FASD?
Yeah, actually, most of the clinics who participate in the database also engage in regular webinars and learning and knowledge translation activities with CanFASD. So we have a newsletter and webinars that go out all the time, and training events that go out all the time to clinics who participate in the data set. So yeah, many clinics are very interested to hear about what we're learning from the data.
Someone commented, thanks for clarifying the sex findings. Do you think the data is longitudinal enough to get clarity? In my experience, assessments are one and done, so only capture that moment in time.
That's a really good question. This data was not longitudinal at all. So it was a cross-sectional study where it was a snapshot of one point in time, and that's when the individual was at the clinic. So it's not longitudinal enough to see what happens over time at the individual level. What we were able to look at was trends in age groups. So at the time of assessment, young children or adolescents or adults had these certain profiles or patterns of experiences, but we couldn't look at anything longitudinally because it's a cross-sectional data set. But it's a really good point that it is very situational for some folks who come to clinic for assessment. So it wouldn't, I mean, actually, some of the clients come for reassessment. So we do code whether a person is coming for reassessment, but even then, because it's anonymous, we wouldn't be able to link the reassessment data with the original assessment data. So another significant limitation of the data set is that it's not longitudinal.
Next question is, have you worked with Dr. Jackie Pai and her Towards Healthy Outcomes team to integrate what you've learned from this research into their framework for supporting people with FASD?
I sure have worked with Jackie Pye. I work with her on the daily basis. We have not specifically woven this study into the new Towards Healthy Outcomes model because we released 2.0 a couple of months ago, THO 2.0 a couple of months ago, and I don't think that this study was published yet when we were revising the Towards Healthy Outcomes model, but we certainly use what we're learning in studies more broadly to inform the THO model, but not this one specifically. That's a great point because I know that there is within Towards Healthy Outcomes, there's this whole section on identity, and I think gender identity and is very relevant to this conversation. Thanks for pointing that out.
Thank you. Why do you think males had more pronounced brain impacts from prenatal alcohol exposure?
It's a really good question. And I think that don't know the answer to that specifically, but I do know that in general, regardless of prenatal alcohol exposure, males tend to be more vulnerable across life. So I like life expectancy is shorter for males. There are higher rates of medical issues and complications in little baby boys and baby girls. I think there's just something about biology and genetics that renders male bodies more susceptible to harm. And I don't know why. I don't know why that is, but it's universal. It's not just specific to FASD either.
Thank you. Next question is, why do you think the co-occurring health needs vary so much between the sexes?
That's a good question, and I think that probably I think that it relates to both biologically based, sex-based factors like genetics and immune system and metabolism, or just the female body versus the male body, um, combined with gendered expectations and responses. So I think if you combine um, biological differences in, say, externalizing or internalizing behavior. So if boys are more likely to engage in externalizing behavior, then they're more likely to be, like I said, mentioned earlier in the presentation, they're more likely to be flagged or trigger a clinical assessment because the behaviors are more obvious. They will be more likely to be diagnosed with a behavioral disorder rather than something more internalized. Um, so I think that's a great question that I think I could write a whole maybe chapter on. Don't think I could answer succinctly, but it certainly has to do with both biologically based, sex-based differences and the way that we conceptualize gender and we respond in gendered ways to people.
I think this might be our last question because we're coming to the end of our time today. But why do you think differences between the genders become more apparent during adolescence? Do you think it relates in part to hormones and puberty?
Yeah. Oh, really good question. I certainly would think so. I would hypothesize that for sure. I think that, again, there's both factors at play. I think the sex-based differences like puberty and genetic differences and hormonal changes, and there's so much brain development during adolescence too, combined with the expectations that we have. So when you're an adolescent, you're encountering social systems more than when you're a little kid. So you're being more involved in the school system and other the healthcare system, other systems that have gendered conceptualizations of what males and females are supposed to be and how they're supposed to behave. So I think both the underlying biological brain-based factors interact, and because adolescents are more the intersection between that adolescents have with those social systems is greater and more pronounced when they reach that life stage.
Thank you so much for your presentation today. I'm just going to close that off then. So thank you to Dr. Katy Flannigan for this wonderful presentation and for our participants for listening from across the province. Take care, everyone, and stay tuned for more webinars by Health Nexus. Thank you so much, Dr. Flannigan.
Thank you so much. Have a good day.